At this point, we will be introducing our speakers. Okay, so like I mentioned, we have two speakers today. I will introduce them both, and the next voice you will hear after mine would be Dr. Zainab Mahmoud's voice. Dr. Zainab Mahmoud studied medicine in Trinity College, Dublin in Ireland. She served at Aminu Kano Teaching Hospital. She has a diploma in tropical medicine from the London School of Hygiene and Tropical Medicine and a master's in health policy from Imperial College London. She was a resident and chief resident at Pennsylvania Hospital of University of Pennsylvania. She completed her cardiology fellowship with a focus on cardio-obstetrics at Washington University in St. Louis, and she has stayed on as faculty. She has been awarded the American College of Cardiology Merck Fellowship Award to conduct research in hypertensive disorders of pregnancy in collaboration with the University of Abuja Teaching Hospital. So she is doing a lot of research within this area, and she's passionate about improving maternal care in Nigeria, in the United States, and of course, globally. Welcome everyone. Please, a round of applause and thumbs up for Dr. Zainab Mahmoud in the chats, please. We would also be introducing our second speaker, Dr. Malachi Emeka Ayogu, who obtained his Bachelor of Surgery, Bachelor of Medicine at University of Nigeria, Nsukka, and his postgraduate training in obstetrics and gynecology at University of Abuja Teaching Hospital in Gwagwalada, Abuja. He's a fellow of West African College of Surgeons and a fellow of National Postgraduate Medical College of Nigeria. He's a practicing consultant obstetrician and gynecologist at University of Abuja Teaching Hospital, Gwagwalada, and his research of interest is fetal-maternal medicine. So he is vast in this sector as well. He has over 12 publications that have been published in peer-reviewed journals, including international journals. He's married with children. He is passionate about this work and about saving lives. So again, thumbs up and a round of applause for Dr. Ayogu. Thank you so much. And so over to you, Dr. Mahmoud, as you take us through the session.
All right, I didn't get a chance to test my sound. I hope you can hear me okay.
Yes, we can hear you loud and clear.
Perfect. Well, thank you for the kind introduction. Welcome to everyone, and we'll get right into it. And thanks for joining us from everywhere across the world, I guess. So next slide, please. Next slide. So I'm going to start with just an outline of what we're going to cover today. So it's right from talking about the spectrum of hypertensive disorders of pregnancy. We'll review the risk factors, how to diagnose, how to manage these patients, and also complications that might arise. We'll save time for questions and answers at the end. I have this red star on here because it's to draw attention. There's going to be a lot of information passed on today. And every time you see this red star, I know you may be zoning off or falling asleep. It's time to wake up. So every time you see a red star, please pay attention, extra attention. I know you'll be paying attention. All right, let's go ahead. Next slide. So I thought it would be good to start up with high blood pressure. I know this has been covered previously on prior talks, but this is a good foundation and the baseline to start. What is abnormal blood pressure? So this is from the WHO and International Society of Hypertension classification. This is what Nigeria uses, and this is similar across many countries. I hear that the audio has a lot of echo. I hope it's okay. Actually, can you go back to the last slide? So what is high blood pressure? Anything greater than 140/90 is considered hypertension class 1. Normal ideal blood pressure, 120, less than 120/80. I hope everybody can hear me okay. Adara, there's too much echo? I can't.
Oh, I can hear you from my end. I see one or two people say there's an echo from theirs.
It may be helpful to mute yours. Everybody, I guess everybody is muted.
I think everyone is muted as well. Everyone is muted. And so we can hear you. It's probably a network situation from the other end, but we can hear you.
Okay. So these classifications are important, especially during pregnancy. And also something to think about. Sometimes people don't always fall into the separate buckets. You could see a patient with a blood pressure of 120/90, for example. So what do you do there? What class do you classify them in? So what you use is the most abnormal blood pressure. So in that patient who has a blood pressure of 120/90, the 90 is the abnormal one. So that patient will fall into hypertension class 1. For example, if a patient comes in with a blood pressure of 145/70, the bottom number is entirely normal, but the top number is abnormal. So your classification will go by the top number, which will be hypertension class 1. So this is important to know what is normal and what is abnormal as we get on with this talk. Next slide, please. All right, so now this talk is going to be about pregnant women and high blood pressure. As we know, during pregnancy, there are a lot of changes that happen, normal changes that happen during pregnancy. So this is a meta-analysis from the University of Oxford, where they put together lots and lots of studies and looked at lots and lots of women to see what normal pregnancy looks like. They had 39 studies with over 36,000 pregnant women. They measured their blood pressure and heart rate in the study, and they summarized for us what we know happens during pregnancy. It's important to know what happens during normal pregnancy so you'll be able to detect what is abnormal. So in a normal pregnancy, as you start up with a blood pressure, it starts to come down all the way till mid-pregnancy, and then it starts to rise up again. With your heart rate, what happens is it starts off from a normal level and continuously rises until the end of pregnancy. So why does this happen? Because the hormones that pregnant women have in their body makes changes and creates changes in their blood vessels. These create changes in the blood pressure. And as the pregnancy progresses, there's a lot more blood volume towards the end. So your blood pressure naturally rises towards the end. But even with a normal rise in blood pressure, there is abnormally high blood pressure, which is what we're going to focus on. Next slide, please. Okay, so this slide is really to get in our minds what is the classification. So 20-week mark is what we consider when we classify things in pregnancy in regards to high blood pressure. Anything below 20 weeks is something else, anything above 20 weeks is something else. 20 weeks is kind of smack in the middle of second trimester. Next slide, please. So anything less than 20 weeks, we consider chronic hypertension. What does that mean? You see a pregnant woman who's like 18 weeks pregnant. Her blood pressure is elevated. She has chronic hypertension. That is in the absence of any other symptoms or complications. That patient, by definition, has chronic hypertension. And if you see that pregnant woman, you saw her for the first time and she's 22 weeks. She's never seen a doctor before and her blood pressure is elevated. She's 20 weeks. That, by definition, is gestational hypertension. There are other classifications and entities that we'll talk about subsequently, preeclampsia, eclampsia, and all the others listed. All these are diagnosed at greater than 20 weeks of gestation. So anything below 20 weeks, abnormal high blood pressure, abnormally high blood pressure, less than 20 weeks, chronic hypertension. Greater than 20 weeks, it could be either of these entities I listed there. Next slide, please. So just to get into a little bit more detail, the top, like I mentioned, is abnormal blood pressure that we talked about. The patient has to be less than 20 weeks. So that's chronic hypertension. Gestational hypertension, new onset, meaning this patient has never been diagnosed with high blood pressure in the past. New onset, this is the first time that it has been detected. Blood pressure is high and she's more than 20 weeks gestation. Okay, I'm going to stop here because some people will say, well, how do you differentiate chronic hypertension between gestational hypertension? If the patient came in 22 weeks, what if their blood pressure was elevated the whole time? Well, we can't know. We can't make decisions based on what we don't know. So what we can do in that situation or scenario is we'll diagnose the patient as gestational hypertension, and then we'll see what happens after she delivers. By definition, gestational hypertension only happens during pregnancy. So if this persists beyond pregnancy, and the cutoff is 3 months, 3 months after pregnancy, blood pressure is still elevated. Well, that is no longer gestational hypertension. That is now labeled chronic hypertension. So you will change your diagnosis from gestational hypertension to chronic hypertension. Okay, so the other entities which are more serious, preeclampsia, eclampsia, chronic hypertension with superimposed, and HELP syndrome. Preeclampsia is essentially somebody who has gestational hypertension and has at least one other abnormality. So think of all the organs that you know in the body, right from the kidneys to the liver to the heart to the brain, everything. You just need gestational hypertension and one other abnormality. So the kidneys, you can think about proteinuria, meaning protein in the urine, acute kidney injury, AKI, which is elevated creatinine. The liver, you can think about elevated liver enzymes. Neurological, meaning the brain, you can think of either altered mental status, severe persistent headaches. If you think of the heart and lungs, you think about pulmonary edema, which is the patient that comes in short of breath, fluid in their lungs. Hematologic, which means something to do with the blood system. And what we see here is hemolysis, meaning breakdown of red blood cells or low platelets. And then uteroplacental dysfunction, which means something wrong with the placenta. So it could be IUGR, meaning small baby, abnormal Doppler on the baby, or something is wrong with the baby in general that the baby needs to be delivered, fetal distress. So that by definition is preeclampsia, gestational hypertension, and a complication of end organ damage. Eclampsia is essentially preeclampsia. Sorry, go back last slide again. Preeclampsia with seizures. So if a patient has preeclampsia, it's not treated, they can progressively go on to have seizures, which can be fatal. So this is a very important entity. And then other things like chronic hypertension with superimposed, meaning the patient had hypertension throughout pregnancy and then subsequently develops preeclampsia. HELLP syndrome is really a severe form of preeclampsia. The H is hemolysis, the EL is elevated liver enzymes, and the LP is low platelets. These are part of kind of the diagnosis of preeclampsia, but in this patient, it happens all at the same time. So that patient will have HELLP syndrome. Next slide, please. All right, so we talk about hypertension, gestational hypertension, chronic hypertension, preeclampsia. Why is this important? This is very important, and my staff has appeared here, so it's time to pay attention, extra attention. So 1 out of every 5 women that die across the world are in Nigeria. That is a staggering number. That's like 20% or 23% of maternal deaths that occur globally is a Nigerian woman. That to me is shocking, because if you think about it, Nigeria really contributes about 2% to the population, but yet 20% of women that die from pregnancy are in Nigeria. So for me, we all deserve to stop and do something about this. And when we look at what kills the women during pregnancy, hypertension is one of the leading causes. And these deaths are preventable. So there's sometimes when you treat a patient and the patient is very sick, you've done everything you can, the patient still dies. That to me is slightly different than a death from a disease that's easily diagnosed, easily treated with very cheap medications. So I firmly believe that no woman should die from hypertension, which is completely, entirely preventable. And why do we care as well as for people like me, cardiologists who take care of people with heart disease. Down the line, we know now that people who have had preeclampsia when they're in their 20s and their 30s, they come back in their 40s, 50s, and 60s with heart failure, strokes. So we also use this time as an opportunity to change their risk of future heart disease. So next slide, please. So sometimes when we talk about things like that, it seems very abstract. You're like, oh, that's something that happens all the way over there, not in Nigeria. So I wanted us to look at data from Nigeria. These are patients just like you and I, or people in Nigeria, at least I know there are people from elsewhere. These are people like us who die from pregnancy. And this is from a study that from our colleague, Dr. Ayogu, who's on the call here. They looked at 240 pregnant women who came into the University of Abuja Teaching Hospital. Try to follow them through pregnancy and see who developed hypertensive disorders of pregnancy. And up to 20% of these patients or pregnant women had hypertension in pregnancy. So you can see this is here. It's happening right here where we are. Next slide, please. And again, this is a slide. This is from work from Dr. Akaba, who's also at University of Abuja Teaching Hospital. What they did here was they looked at deaths. So they looked at pregnant women that died during pregnancy and tried to figure out why did they die. And what they found out was preeclampsia, eclampsia again was the #1 leading cause of death. And this again, a pregnant woman right here in Abuja. Next slide. I know that people that are also not from Nigeria. So again, it's the same thing really happening across South Asia, Sub-Saharan Africa, and most other countries. It's like preeclampsia, hypertension, they are leading causes of deaths. So I circle there in the red, up to 10% of deaths are from hypertension and 2% are for preeclampsia. So I hope I have convinced everybody on this call that this is a very important topic. These are pregnant, young, otherwise healthy people who die just because they're delivering a baby. I think that shouldn't happen. Next slide, please. Okay, so it's important to know about the risk factors so that when we come across pregnant women, we can start to think, is this patient at increased risk of high blood pressure during pregnancy? Should we pay extra attention? So what are the risk factors? If you've had preeclampsia, prior history of hypertensive disorders of pregnancy, you're likely to have it again. Multiple gestation, if you have two twin pregnancy or triplets or more than that, you're likely to have it again. Nigeria has the highest rates of twin births in the world. So this is especially important, I guess, in Nigeria. The thought is preeclampsia is mediated by factors from the placenta. So when you have one placenta, you're at some risk. When you have two placentas, you're at higher risk, and three and subsequently that. Other things like diabetes, chronic kidney disease, they all, through their pathophysiology, affect blood vessels, and these also increase your risk of preeclampsia. Other factors that we know are people who are overweight or obese. Now, the parity, for some reason, meaning if it's a woman's first pregnancy, she's at higher risk. Advanced maternal age, so any pregnant woman who's over the age of 35 years old is considered advanced maternal age, and they're at higher risk of preeclampsia. I put a young age there. There's some for the adolescent pregnant women at higher risk. There are some studies that have conflicting evidence, but in Nigeria, we do consider young age to be at a higher risk of preeclampsia and hypertensive disorders in general. Next slide, please. All right, so I know we have a huge spectrum of people on the call, and I thought it was important to look at pathogenesis of preeclampsia. The bottom line is we don't exactly know for sure, like a lot of things in medicine, but we have theories and thoughts of why this happens. And part of the theory is a woman has some risk factors, whether applied, genetic, environmental, immune factors that predispose that woman to having preeclampsia. And when the placenta starts to develop, there's some abnormal development that occurs, and the placenta then becomes hypoxic, meaning it doesn't get enough oxygen. And when anything doesn't get enough oxygen, you get stressed. And when you get stressed, the placenta releases some factors, anti-angiogenic factors, that causes abnormalities within the placenta, and then subsequently affect the organs, from pulmonary edema in the lungs to PRES or preeclampsia in the brain, cardiomyopathy, abnormal heart function, high blood pressure in the blood vessels or abnormal platelets, and so on and so forth. So this is thought to be due to placental issue. Next slide, please. All right, my red star has appeared again. So symptoms, I think it's very important to realize that although we talk about symptoms and what you look out for, that some pregnant women may be entirely asymptomatic. And that is why it's important to have regular prenatal checkups or antenatal checkups. During these antenatal checkups, things like elevated blood pressure can be picked. And just when you see an elevated blood pressure, it's time to pay attention, because that woman either could have preeclampsia or could be at risk of preeclampsia. And it's important to realize that some pregnant women may be asymptomatic. I always tell pregnant women when I do see them in clinic, if you have a headache, don't be like, I'm fine, I'm gonna go to bed. Always check your blood pressure if you can, because that could be a sign of preeclampsia. It can occur at some point during your pregnancy, and it could be when you least expect it. So headaches, visual abnormalities, blurred vision, transient vision loss, the light bothers you, abdominal pain, confusion, shortness of breath. I can't lie flat because I'm too short of breath. The last two can be a bit tricky because a lot of pregnant women can get short of breath as part of normal pregnancy physiology. But usually pregnant women themselves will detect a difference. They will detect a change. I'm usually short of breath, but this is slightly different. Listen to them, listen to their complaints when they report those things. Next slide, please. All right, I want to just take a moment and talk about gestational hypertension briefly. Dr. Ayogu is going to cover this in a little bit more detail, but I know there's a lot of people from primary healthcare centers here on the call. You may come across a lot of women who may have gestational hypertension, which is, like we talked about, elevated blood pressure greater than 20 weeks of gestation. And the important goals to think about when you see these patients, one is to make sure that this is not just white coat hypertension, meaning some pregnant women or patients in general, they come into the doctor, they are nervous, their blood pressure can shoot up. It's always important to recheck. Exclude preeclampsia. Like I said, preeclampsia can be very sudden, so it's important to exclude and make sure this is not dangerous. And if you don't have the facilities to do that, the best plan of action is to refer that patient. Assessing severity, assessing fetal well-being to make sure that the baby is okay, and also the next step will be management. Next slide, please. All right, I think this might be my final star. So, talking about antihypertensive medications in pregnancy, sometimes pregnant women or women can be on medication for high blood pressure, and then they figure out that they're pregnant. It's important to realize that these medications can be harmful to the baby, can cause fetal defects. So ACE inhibitors, ARBs, and mineralocorticoid receptor antagonists, which I've listed here. You see a patient on this and they're pregnant, it's important to stop it, but not just only stop it, also make sure they are appropriate medications that are safe during pregnancy. And there are other medications that we use sometimes, but we use only when we have to, which I've listed at the bottom. And but it's important to, when you see a patient, to make sure that the medications they're on are safe during pregnancy. And also, I always use this opportunity to remind people, sometimes you have patients that are not pregnant, but they are young and could get pregnant. It's important to make sure that you educate the patients that these medications you're on are not safe during pregnancy. So the moment you find out that you're pregnant, you need to come back and see your doctor so that you can be changed to medications that are safe during pregnancy. I think this may be my last slide, but maybe advanced. Yeah, so I'm going to hand over to Dr. Ayogu to talk about management complications, and we'll be here to answer questions at the end. Thank you so much.
Thank you so much, Dr. Mahmoud. Dr. Ayogu, can you hear us?
Hey.
Okay, wonderful, wonderful. I think some of Dr. Ayogu's colleagues have also joined the session using his link. So we have like 3 Emeka Ayogus on the call. So please, if you are not the real Dr. Emeka Ayogu, can you please rename yourself on the platform? All you need to do is click on the button close to your name and you see rename. You can rename yourself so that we have only the real Dr. Ayogu speaking. Thank you so much, sir.
Actually, I'm using my laptop as well as my Android phone. Maybe
okay. So that's fine. That's fine.
Why I can see everything in my laptop, and the audio appear not to be there, so I have to resort to Android phone as well.
Not a problem. Thank you so much, sir. Okay.
Good afternoon, moderator. I also wish to thank the lab presenter, my colleague, Dr. Mahmoud. Thank you for the job well done. I'll be talking from University of Abuja, Teaching Hospital, and I'll be talking about the management of this very condition. Let us know that without being overemphasized, the cause of maternal mortality and perinatal morbidity in developed countries and developing countries actually is this very condition that we are mentioned. Next slide, please. So, next slide. So I'll be talking about investigation briefly. Let us remember that this is a multi-systemic disorder that affects all parts of the body, including of course, all parts of the body. So you need to realize this appear to be key, especially preeclampsia, eclampsia. Full blood counts, it affects full blood count, platelet counts, and even the kidney, the liver, and the clotting profile need to be done because, just as I said, it affects all the system. Ultrasound needs to be done to at least assess the fetal well-being and by doing the Doppler velocimetry and umbilical velocimetry. So because it affects the eye too, as I said, one need to do other tests that include fundoscopy. So this could also know how the eyes are affected. Please, next slide. So I'll be talking about management of these very conditions. And management depends on the type of hypertensive disorder in pregnancy. However, I'll start with the mild gestational hypertension, which of course is pregnancy-induced hypertension also. For this condition, of course, we should know that all these conditions need to be referred to a specialty health center where optimum approach can be applied. But for this very mild gestational hypertension, one can consider use of oral hypertensive, which include alpha-metidopa, otherwise called Adamet, for very popular ones we use here, and then nifedipine, as well as labetalol. Frequently, another visits may be needed to check effectiveness of medication so that it's not something you just do once and they say, think you have achieved a cure. This condition cannot be actually cured in pregnancy until baby is delivered. Therefore, fetal surveillance and maternal surveillance continue throughout the pregnancy. Deliver at 10, of course, and is advocated to deliver through vagina, unless there's other obstetric indications. Target blood pressure below 135 millimeters of mercury to 85 millimeters of mercury. So that is when you can do the assess have achieved control. Next slide, please. So severe hypertension, which is another type, this one require an inpatient management. You have to admit the patient for stimulation. In this case, intravenous routes appear to be the drug of choice. Method of approach. And we usually use labetalol in this environment, in those environments, and hydralazine. Of course, in terms of efficacy, both these two drugs are very efficacious. It's just that labetalol appears to have a better control over mean arterial blood pressure. Otherwise, ROCG and ACOG have actually suggested, of course, recommended these two drugs, as well as WHO. Pregnancy may continue till 10 if blood pressure is achieved and no signs of fetal compromise. This is the only condition you can allow the pregnancy to continue. Otherwise, you should know where to intervene. Next slide. This of chronic hypertension, this is, of course, just like Dr. Mahmoud described, this hypertension that usually occurs before mid-trimester, 20 weeks, or hypertension that beyond 12 weeks after delivery without proteinuria or any other adverse condition. This may be due to essential, of course, that are common in other population, not pregnancy, can be there with every other person that is, of course, of age. Can be due to endocrine disorder, due to, in this case, diabetes and hyperthyroidism, can also be due to renal disorders for those who have a chronic renal failure. And who diabetes, of course, have affected the kidney, leading to the diabetic nephropathy, and also acute renal failure for other conditions. Other things that can also vascular disorder, like coarctation of aorta. All these things there are numerous things, but for the sake of time, I won't like to be talking about things that cause chronic hypertension, but there are numerous. These are the ones that should bother us for now. Next slide, please. So in management of this hypertension, chronic hypertension, you need to convert it like angiotensin converting inhibitors. I think she enumerated it, so I will not repeat. These are drugs that appear to have some teratogenic effects on the pregnancy. Some of them were on it before they got the back on the voyage of pregnancy, and therefore some of these drugs need to be removed. There are angiotensin reverse blockers and the diuretics. So you have to consider using alpha-metidopa, labetalol, and ephedrine, which are safe in pregnancy. So, and of course, where you think you want to prevent preeclampsia, you have to consider aspirin for those who are at risk of developing preeclampsia. Otherwise, it's called chronic hypertension with superimposed preeclampsia. You have to introduce a training to prevent that from 12 weeks of gestation. And because this hypertension must have existed before pregnancy, the effect, the trauma on the effect of pregnancy must have been there early enough, and therefore this is a candidate must do what we call anomaly scan between 18 weeks and 22 weeks. And of course, proper antenatal care is also advocated. You aim at delivering at 10, unless there's other obstetric indication to intervene. And target blood pressure below 135 to 185 over 185 millimeters of mercury. Next slide, please. So this is another very serious condition that appears to affect our people, especially in this part of the world, developing countries. It's a very serious medical problem, and of course, not that cannot be seen in advanced part of the country, but it appears to be a major problem having this part of the world. Kill our women and kill our babies as well, and have my type as well, which blood pressure between 140 and 90 for 140 over 90 to 150 over 109 is considered to be mild. Otherwise, 160 over more than 190 appear to be severe type. So managed expectantly with bed rest can be allowed in my type. Oral hypertensive, of course, the popular ones I've earlier mentioned, alpha-metidopa, nifedipine, labetalol can also be used. Monitor closely to onset of for onset of severe features, and this is where you may need to do something very aggressive. Well, once there's no aggressive, a severe one can carry pregnancy to term and deliver. Next slide. Next slide. Okay. Severe preeclampsia. This is a very serious medical diagnosis, as earlier mentioned. It's a cause of fetal morbidity maternal morbidity and mortality. For this one, intravenous drugs, antibiotics are advised, and we still use the labetalol, hydrolyzine, to mention with a few, to control, aim is to control or prevent convulsion, because that is the peak of the event. You need to control and prevent convulsion, because that's the next step that could occur. And they also know that there's a way to manage fluid because of this condition. It causes pulmonary demand. If you don't manage fluid very well, it can lead to death. Iatrogenically, can cause the death of such a woman if you don't manage fluid well, as well as electrolytes. Best treatment is actually delivery. That's the only way you can achieve a cure. Deliver via safest and fastest means, meaning that for these patients, you have to follow the extent routes to deliver them. And room for conservative management in center square fetal maternal condition can be closely monitored till 32 to 34 weeks. This is a gray area. Some want to deliver at 32 weeks, some want to deliver at 34 weeks, once at 34 weeks. In our environment, yes, we also want to take it to 34 weeks as much as possible. Why is not possible? Yes, 32 weeks appear to be gray area where some people will say, okay, leave or stay. But in any case, the maternal condition appears to be paramount in this state. And if you are living before 34 weeks, you have to give anti-cholesterol, which can be dexamethasone or betamethasone. But here in the environment, we are more comfortable. Other than the available steroid is dexamethasone. So you deliver if the gestational, this is what to do here. Unless where you need to do it earlier than because of other condition you must have seen, which you can gestational age. Next slide. Irrespective of maternal, the gestational age of the pregnancy, you have to deliver because it can lead to the death. So, and then why you have hemolysis with thrombocytopenia? Of course, this is a condition with the liver function test, and find that all transaminases are increased. For progressive symptom of imminent eclampsia, headache, visual disturbance, epigastric pain, vomiting, pulmonary edema, renal compromise with oliguria, or fetal heart rate abnormality. These are conditions where you need to terminate the pregnancy of the gestational age because, of course, it's a progressive condition. You cannot achieve a cure unless deliver. So, and that's why you need to terminate mother, if possible, save the life of the fetus, if possible. Next slide. And the severe preeclampsia, this is why we have to introduce magnesium sulfate to control marks of according to preacher regimen. That's what the regimen we offer here. There's also another regimen called Zuspa, but both are very efficacious. Zuspa here because of maintenance dose, which require intramuscular. Preacher requires intramuscular maintenance dose. Which you need to titrate with a measured instrument. So in this case, elsewhere to offer the Zuspan's regimen. But for us here, we prefer to use the preacher regimen because it's easier for us to maintain, to be sure that appropriate doses are given. They are given 5 mg for hourly after the loading dose. Unlike a preacher that is given 1 gram hourly for the next 24 hours or after the last conversion, whichever one occurred last. And this point, very good drug, but you need to watch out for toxicity. Next slide. Next slide. Yeah, anticonvulsant therapy, which I've said is a magnesium sulfate. And you have to monitor respiratory rate. Of course, respiratory should not be less than 16 cycles per minute. How you have to hourly patellar reflexes. These are the areas affected. Hourly urine output, at least the renal function must be at least renal output must be at least 30 minutes per hour. And you also manage of course, where you have the guidance, you need to check the concentration of magnesium sulfate in the body. It shouldn't be more than 2 to 5 millimole per liter. 2 to 5 millimole per liter. So why does toxicity? You can have a loss of patellar reflexes depending on the concentration of magnesium sulfate in the body. It's measured. Feeling of warmth, usually 9 to 12 milligram per gel. Slow speech, 10 to 12 milligram per gel. Muscular paralysis and respiratory difficulty. These are depends on the dose. And why this thing? That's why you need to have the antidote just beside the patient. So anytime you're treating marks off, whether you're in a rural area, why you want to produce it, there should be an antidote we call magnesium calcium gluconate, which once you give, it tells you how to neutralize the effect of this toxicity. Therefore, my advice that wherever you want to introduce this, whoever, once you have access to magnesium, you also have access to calcium gluconate. It's readily available in this part of the world, and then I believe it's also available elsewhere. Therefore, you should make sure you have it just beside patient's bedside, so that you won't, because of trying to prevent convulsion, and teach patients any of these side effects and formations. Next slide. Yes, eclampsia. This is the hallmark of this condition. Any of them can lead to chronic hypertension, can eventually become eclamptic. That's part of reposition. Severe gestational hypertension can, just a thin line, can lead to preeclampsia, from preeclampsia to eclampsia. And just like that. So it is a spectrum. I don't know if I'm can lead to this. So for us, principal management here means stabilize patients using the ABC of resuscitation. We prevent aspiration and injury, regular suctioning. You have to guard and padded tongue, because they tend to bite themselves during the course of convulsion. This can cause more trauma to the patient. Of course, the aim here is to control blood pressure, control or prevent further convulsion, and fluid and electoral management, just like you did in severe preeclampsia. Here, convulsion are taking place already. You need to control it, and not only control, you have to prevent further convulsion. For any actual convulsion lead to severe mortality, morbidity, go to the mother and fetus. And the next thing is to deliver via safest and fast means, irrespective of gestational age. No room for conservative management. Usually, the teaching that you stabilize within 4 to 6 hours and deliver, irrespective of gestational age. So, because of the attendant consequence that could follow further conservative approach. Fetal monitoring based on the taking an inpatient basis. Therefore, this patient must be admitted. Of course, it must be in a tertiary health center. It's not a case that can be handled in any of the other health facilities like primary or secondary. But be that at may, where magnesium sulfate is available, you can just give a loading dose and refer patient immediately to the tertiary health center, because it's beyond stopping the convulsion. Record the patient can make aspirator. You may not have all this what it takes to resuscitate the patient. Just give a max off to prevent further convulsion and refer to these centers we are talking about. So, and therefore, I've suggested something that it must be a case that must be referred for inpatient management in a tertiary health center. Next slide. Yes, complications of this condition are very, very numerous. There are plenty and they are very, very life-threatening. Of course, I've said convulsions from preeclampsia, gestational chronic hypertension, blindness at no core due to cortical injury, detachment. I can also pulmonary edema, either from hypogenic overload of fluid, because the space, the very transvarsal spaces are usually contracted, and anything you give may not really work so much. So you need to manage, see how you can deliver appropriate fluid, usually 1 ml per minute per hour. 1 ml per minute. In this case, now you can't do more than 100 ml in 1 hour. 8 minutes in 1 hour, depending on the weight of such a patient. And again, recall that it's a cause. I told you that in the end here that it causes heart. It's a multi-systemic disorder. That means that it can cause heart failure. Of course, after you can, there is renal affection. It can cause oliguria, poor urine output. It can cause, of course, cerebral accident, because it affects brain, pulmonary edema, and cause being a hypertensive disorder. It can also have a cerebral accident and or tender consequence. HERP syndrome, because it affects the liver and cause hemolysis, and so on and so forth, and cause disseminated intravenous coagulopathy. Postpartum hemorrhage, of course, is a common condition. Pre-embolic events, and ultimately death. These are maternal complications. Apart from that, there are also fetal complications. And the first, when it starts, before the early in pregnancy, can cause fetal growth restriction, can cause fetal distress, can cause preterm delivery, as we have said that if you have a severe preeclampsia, you cannot manage conservatively, or eclampsia. Of course, if you need to deliver, meaning that it can lead to that. So, again, sorry, complication. Other complications are low ABGA score because of premature delivery, or when there is fetal distress before the whole thing, and again, early neonatal death and perinatal morbidity. Next slide. Next slide, and almost there. Conclusion. Hypertension disorder in pregnancy remain a major health concern for women and their infants. Optimizing management, including prenatal care and education of severe features and treating appropriately, as well as close postpartum follow-up, are key to reduce fetal maternal morbidity and mortality. Thank you very much. I think.
Thank you so much. Thank you so much, Dr. Ayogu. Thank you so much, Dr. Mahmoud.